So I was saying thank you very much for asking me to be here. I've talked a few times before, and I think I was worried that you've all heard me, nothing new to say, and that's obviously was Karen's worry because she asked me to talk about the myths. So I agreed, but I thought I have to put a few facts in before talking about the myths. So I've picked 10 myths, there's many more, which I'm going to explore, but I'm going to start with a few, just update, because how many people have never been to this meeting before, to the AGM? So there's quite a few people who haven't heard this before. So first of all, in terms of CMT, I thought one of the questions is, just to go back to very much basics, what is Charcot-Marie-Tooth disease? And it is a neuropathy. And this is very simple. This was one of the biggest causes of people having myths, is what does a neuropathy actually mean? So if you divide the nervous system, you have the brain and the spinal cord, and that's called the central nervous system. And then you have the nerves in the arms and the legs, and that's the peripheral nervous system. Now that might sound really obvious, and all of you know that, but lots of diseases affect exclusively one or the other, and it's important to remember that basic. Okay, so basically the central nervous system and the peripheral nervous system, and a neuropathy, by definition, is a problem of the peripheral nervous system. So it is the nerves in the arm and the leg, but not the nerves in this brain, the spinal cord. And although there are nerves, obviously, in the brain and spinal cord, and they're very similar to the nerves in the arms and legs, they're actually made up of separate proteins, at least partially, which means lots of diseases can only affect one and the other. And we'll come back to this later on, but that's a very important distinction. For instance, multiple sclerosis is exclusively a disease of the central nervous system, whereas neuropathy is a disease of the peripheral nervous system. So in terms of each individual nerve, that's your spinal cord, that's the nerve going down to a muscle, so that's called a motor nerve. So if I want to move my hand, that's how it happens. The message goes from the spinal cord down to the motor nerve. Whereas this is a sensory nerve. If I feel something with my skin, the nerve message goes back up to the spinal cord. So when we talk about neuropathy, we talk about motor neuropathy, sensory neuropathy, and in the case of CMT, it's a motor and sensory neuropathy. Both sets of nerves are involved. And if we take those individual nerves and look at them in more detail, that's what the nerve looks like. It's a bundle which contains little nerves, and in that are the blood vessels between them to feed the nerves. And this is the same thing seen from an actual patient. So this is a normal nerve biopsy. Again, you see the bundles of nerves and the blood vessel in between it. And if we start looking at that in more detail, and again in further detail, we now are looking at nerves within nerves. So this is a nerve fibre. The central bit is the axon, and the outer bit is the myelin. And how I think of it is, I think of a pipe with lagging. The size of the message is determined by the pipe itself, but the speed of the message by the lagging. So there's problems with the axon, and that in CMT is CMT type 2, and problems with the myelin is CMT type 1. So we were talking about, I can't point as I'm just going to show you, the top diagram is a representation of the normal nerve, with the body of the nerve in the spinal cord, the end of the nerve going to the muscle, the pipe, which is the axon, surrounded by myelin. Now, if you have a problem that starts in myelin, it'll look like 2. The myelin begins to break down, so you begin to develop gaps in it. If the problem starts in the axon, it looks like 3, where the axon begins to die back, but the myelin is still intact. But actually, whether the problem starts with the myelin or the axon, eventually the nerve will die. So even though demyelinating CMT type 1 is like number 2 here, and axonal is like number 3, the end stage is the nerve dies. So they're both talking to each other the whole time, the axon and the myelin. Now, neuropathy is not uncommon. CMT is rare, but neuropathy is not uncommon. And if we think about neuropathies, there's 3 causes. Acquired means things that happen to you during life, for whatever reason. Genetic or inherited are things like CMT, it's due to a genetic defect. And idiopathic is we don't know. Luckily, idiopathic is getting smaller and smaller over the years, but there's still about 10% of people that come to clinic that we don't know the cause. And I suspect most of those will have a late onset CMT, but we haven't worked out the genes yet. So I'm not going to talk about the acquired, but just in the UK, I thought you might be interested to know the commonest cause of neuropathy is diabetes, followed by vitamin deficiencies, alcohol, but a lot of alcohol, just to reassure you. Not a little bit, a lot of alcohol. And toxins, actually that nowadays means drugs. Many different drugs can cause neuropathy, particularly drugs used for chemotherapy. All of the other ones are rare, but when a GP sees someone with a neuropathy, they will think diabetes. It's by far the commonest cause. So neuropathy isn't rare in GP practice. It's just that CMT is quite a long way down the list. And when we talk about inherited neuropathies, we talk about diseases where you have a neuropathy and that's the main problem, and CMT is one of those. But there are a huge number of diseases that are genetic, where neuropathy is part of the disease, and that does give rise to the confusion when people say, I have CMT, but I have this, that, and the other, and other people say, you cannot have this, that, and the other if it's CMT. So it is a little bit of the overlap, which I'll talk about. So when I talk about CMT nowadays, we really mean CMT and the related disorders, of which there are 4 in the group, the family of CMT. There's CMT, there's hereditary neuropathy with liability to pressure palsy, which people will know about if they have it. There's the hereditary sensory neuropathies, and there's the hereditary motor neuropathy. So what do I mean? So if most people, this is just to show you the picture of the 3 people that originally described it, but most people with CMT will present with wasting and weakness of their feet initially. So they'll present with problems walking due to muscles not working in their feet. So people with Charcot-Marie-Tooth disease, even though they have motor and sensory nerves involved, tend to present with the motor nerve problem. But so do people who just have motor neuropathy, that is people with hereditary motor neuropathy. Whereas people who the main problem is in the sensation fibres present with the problems of not being able to feel, which is where you get severe ulcers and damage and you haven't felt it. But it is a spectrum. So CMT and related disorders, the classical type, which most people have, is motor and sensory in the middle. But some people are mainly motor, some people are purely motor, some people are mainly sensory, some people are purely sensory. So it is a spectrum. And we really do think of it as one condition because it often is the same group of genes that affects them. So that's just to help explain these different terms we use. The other thing I think people often ask about is, what do we mean when doctors say length dependent? Well, it's very simple. The longest nerve in your body in CMT tends to be affected first and worst. So no matter how small you are, Alex, the longest nerve is the one to your foot. It starts in your spinal cord and goes to your foot. So feet are always affected first in classic CMT. And as it spreads up, when you get to about the knee, your hands are affected, although you may have some symptoms earlier. So that's what we mean by length dependent. And what does that look like? Well, you will all recognize this. The wasting is worse down at the feet and in the lower legs, and by the time you get to the mid-thigh, you begin to get some decent muscles. So that's the classic length dependent. And if you look at the hands, you'll spot the wasting of the muscles here, the classic place. But with time, some people get it more severely and they get this wasting in the forearms. And that's why doctors always ask you, how long have you had that watch and has it got looser? Have you had to take links out of it? So that's what we mean by length dependent. And of course, to take that further, it gradually, if you've severe forms, can affect shorter and shorter nerves. The other thing just to mention before moving on is, it's very complicated. There's lots of genes because technically we can find them easier. And there's many families that have a unique gene now. This is what's changed. And at last count, there was 85, so it's growing every year. So that makes it quite complicated for individual families, although there's certain 4 types more common than others. So that's really, I was given a very short introduction to the facts. Now, the myths, and hopefully by dispelling the myths, I'll give some more facts. So the first one is about multiple sclerosis and CMT. That is one of the commonest questions we get. Firstly, because multiple sclerosis, because it affects the brain and the spinal cord, is diagnosed predominantly by a brain scan. But MRI scans weren't available 30 years ago. So in family histories, there are people with CMT that might have been misdiagnosed of MS and vice versa. So just because way back in the family, someone had one or the other, it may not be quite right, whereas nowadays, you should get an accurate diagnosis. So for the central nervous system, you do a brain scan. For the nervous system, the peripheral, you do electrical studies. But at the same time, most of you who are in the room will have seen somebody with a stroke. Is that true? At some stage. And they have problems with the arms and legs. So if your nerves don't work in the central nervous system, of course your arms and legs don't work properly. But it's a different cause than neuropathy. So I think these are distinct problems. Now, there's even more complicated with MS because multiple sclerosis affects the myelin, but the myelin of the nerves in the central nervous system, and that's different proteins. But that's why people get mixed up, because people get told they have a myelin problem, and if it's in the central nervous system, it's MS. If it's in the peripheral nervous system, CMT is one of the causes. So that's a very common myth. And a lot of GPs need that explained as well. Secondly, what about CMT and muscular dystrophy? In families, a lot of family histories, they'll find someone was told they had muscular dystrophy. I still see patients who were seen 50, 60 years ago and given a diagnosis of muscular dystrophy. And they are connected in this way. In CMT, it's the nerves to the muscles that don't work. But if your nerve to your muscle stops working, your muscle gets weak and then atrophies, that's the word we use. The muscle dies away and you get very thin muscles. In muscular dystrophy and all other muscle diseases, the primary problem is in the muscle. So the nerve is fine, but the muscle doesn't work. So if we examine patients with muscular dystrophy, they are very weak muscles, but the electrical tests are normal of the nerves. So both need each other. It's a bit like the charities need each other. So you have the muscle, you have the nerve to the muscle. They cannot work independently. But muscular dystrophy is just a motor problem. It doesn't affect the feeling. So it's a problem from within the muscle. That's the differences between them. But in the literature, as you can imagine, many people with CMT were called muscular dystrophy years ago. And there's all kinds of other words, perineal muscular atrophy. There's as many words, actually you should have a quiz on who can get the most words that have been described to call CMT. The other thing, this is quite important, what about hearing and vision? So if you look at my, taken from Google of course, diagram down here, it's to make the point that even though the peripheral nerves supply the arms and legs, they also supply the face. So we feel in our faces, I'm talking, I'm moving, that's all my peripheral nerves working. So our movement, the way we move my lips, the way my eyes move, that's all my peripheral nerves. But there are three bits of this that's to do with the central nervous system. Our sense of smell is all to do with the brain nerve. It is not a peripheral nerve. Our actual vision, the ability to see, not moving the eyes, but the ability to see is in the central nervous system. That's why it's commonly involved in multiple sclerosis. And the hearing is odd. The hearing is a genuinely 50-50. Half it is made up of the central nervous system and half it is made up of the peripheral nervous system. So if you have severe CMT, hearing is very commonly involved because it's a really short nerve. So if you think about the longest nerve to the leg, the ones up here are very short. So eventually they can become involved. And in some forms of CMT, hearing is involved earlier. So hearing can be involved. The problem is hearing loss is so common with age. So I don't know how many people in the room here would say their parents or they, after a certain age, have had hearing loss. It's really common. So it's always difficult to dissect out if it's due to the CMT or not. Vision loss is not due to CMT with one rare exception, a very rare gene. That is CMT2A. So if you have a problem seeing, do not let your GP tell you it's the CMT. So that's the one that we don't like to hear people being told is due to the CMT. Does that make sense? So that's quite an important point. And then the length dependent. So I've just said to you, it usually starts in the legs and moves to the hands, and there'll be someone in the audience saying you're wrong, because there are rare forms. There are some forms that start in the hands, rare forms, but there are forms. There is a not too rare form, X-linked, that involves the hands as badly as the feet. And there's some forms that involve the legs much worse than the arms. There are rare forms that involve the facial muscles and the vocal cords, your speech muscles, before their arms and legs. So every variation possible is out there. But this is what we call typical or classical. But with time, if you have severe CMT, it can move up. So what about the breathing? We're often asked that. So yes, you have some peripheral nerves that go to your breathing muscles, not the lungs, but the breathing muscles. And if you have severe CMT, by the time it's come up to the legs and the arms, there's one of the nerves that goes down to the diaphragm that's pretty long. Actually, I didn't know this until a few years ago, but the longest nerve in a horse is actually the nerve to the left diaphragm, not the long leg nerves. And obviously in a giraffe, it's obvious it's not the leg nerves. So actually you have one very long nerve that goes down to the diaphragm. So in severe CMT, you can get breathing problems. Now, what we now know that we didn't know a few years ago, even with milder CMT, that is CMT1A, there is a higher instance of what's called sleep apnea. And I'm sure there must be people in this room that have it. So sleep apnea is when you're asleep. It tends to be people that snore. Now, not everyone that snores has sleep apnea. I'm sure there's some snorers out there. But when you sleep, some people, when they snore, they basically don't deliver the oxygen as well. They reduce the amount of oxygen they're delivering. And that means you can wake up feeling very unrefreshed and feeling headachy and a tendency to nod off during the day. Now the problem is, if you ask an audience of people, how many people nod off the day or wake up unrefreshed? We all do it some of the time. So, but it is something that's common in CMT. The problem is, the commonest cause of that is being overweight rather than CMT. And the treatment is, there are treatments to help them sleep at night. But if you do snore a lot and you stop breathing sometimes, your partner thinks you stop breathing, remember there is, sleep apnea is a little more common. And it is something now that 5 years ago I wouldn't have asked every patient, and I now ask every patient about it. So it is something important. But most people have no breathing problems with CMT. What about thinking and memory? Now this is no. You do not get problems with your thinking and memory with CMT. So no excuses out there. You can't put it down to the CMT if you're just being lazy. It's all that, that part of the brain is never involved in straightforward CMT. So it's really banging the central nervous system. But I did want to make the point, some people will say, or I'll have an email from Karen or a message saying, my child has, it's usually younger people, has been diagnosed with CMT. They also have learning difficulties. They also have epilepsy. They also have this very complex. And it comes back to this, the fact that you can get inherited neuropathies as part of a much broader genetic disease than just CMT. So I do not define that as CMT, it's a different disease. And there'll be diseases you've heard of, like Friedreich's ataxia. So CMT is just a peripheral nerve problem, but Friedreich's ataxia does involve the peripheral nerves as well as the brain and spinal cord, the brain to do with the steadiness. And then hereditary spastic paraparesis is another condition of the central nervous system. But some of these, we've always known that occasionally you get a neuropathy as part of them. And we haven't been surprised at that, because often the mechanisms are the same. But I think what causes confusion, sometimes these very complex diseases, the very first symptom is a neuropathy. So I have patients who were thought to have CMT for the first 5 or 10 years of life, or even 20 years. But then, when the disease progressed to have other bits involved, we realised it clearly isn't CMT. So complex disorders can look like CMT. So they're not CMT, but they can look like it. But that's why you might wonder, why are we so focused when we see patients at making the right diagnosis? Because, you know, people will be nihilistic, like some GPs will say, and the health services. Why do you need a diagnosis for a disease that we don't have curative treatments? Well, part of it is to get the right diagnosis, because as you know, usual CMT does not reduce your lifespan, but some of these complex diseases that have a neuropathy as part of them can have a totally different prognosis, and also mean that other parts of their bodies may be involved, like hearts, etc., that have nothing to do with CMT. So that is one of the reasons we're very keen to make the right diagnosis. Now, with most forms of CMT, it's easier because people come to clinic and they have a family history. This more relates to those very unusual patients that present for the first time in a family, often with a complex disease. But that's why you'll always have someone saying, but I know someone with CMT that has this, that, and the other. It probably isn't the right diagnosis. Does that make sense? That's quite an important question that people ask. And that's my latest diagram. Don't worry, nobody. It's a picture from up to date now. The big circle on the outside, or square, is neuropathy, and that is all the other hereditary conditions I can now find that have neuropathy as part of them. So there's a massive number of them. They're all very rare. Some of them have epilepsy, some of them have problems with memory, some of them have problems with muscle, but they are not CMT. But this is what we're trying to help people understand, that there's this vast majority of conditions, all incredibly rare individually, but they're not CMT. But that's where the confusion arises. So we now medically think about CMT as being a sole neuropathy, the complex disorders, and I now have a third group I call the complex disorders that look like CMT initially, just so people will keep an open mind. If something odd happens, to remember it mightn't be CMT. Now, pain in CMT. Now, can you get pain with CMT? So when I was a medical student, we were told you don't get pain with CMT. You just don't see pain with CMT. And, of course, you do get pain with CMT. And one of the questions is, why and what type of pain? Well, I've already told you that even though the sensory nerve mightn't work properly, in some forms of CMT, those unmyelinated, those naked nerve axons still work, and they're the ones we use to feel pain. And it's a very common question from patients. How can I have pain, tingling, pins and needles, when I cannot feel? How can I have freezing cold feet and numb feet and still exquisitely sensitive if someone touches them? It's because of those nerve fibres. And yet, when we looked at this as part of the vitamin C study that CMT UK were involved with, we dissected out pain in a lot more detail. And with CMT1A, 88% of patients had pain. So, 88%. So a lot of people have some pain. I mean, pain, most people have pain at some stage in their life. I mean, if anybody here said they've never had pain, I think they need a medical opinion, because there's probably something wrong with their pain fibres. Because pain is a natural protection. If you drop something on your foot, you move out of the way because of pain. In 61%, it was mainly feet, and I think that makes sense. Number one, the feet, nerves to the feet are the ones most involved, but also, you use your feet to walk the whole time. And if the feet don't work, it's common to have pain. And this is what I think the next couple of figures are important, because I think they're probably the correct ones. About 20%, that's 18%, even with CMT1A, it was nerve pain. Although it's rarer than other forms of pain, you do get nerve pain. And there are a lot of doctors that still think you don't get nerve pain with CMT1A. It's not common, but you can get it. And that's 20% of people had some nerve pain. And the reason is these naked axons. But the vast majority of people, 70%, it's musculoskeletal pain. Pain due to the fact that your bones and muscles and tendons are all disrupted because of the nerves not working properly. And all of you know about these kind of pains, the ankle pain, the secondary pain to the knees, the hips, the back, because you're not walking properly. And it can be very complex in the foot, the pain. It can be very difficult. People can have plantar fasciitis. People can have all kinds of complications. So if you look at marathon runners, look at all the problems they get. Well, with CMT, you're doing your little marathons the whole time because you're starting with feet that don't work properly. So musculoskeletal pain is very common. And seeing someone that understands the different causes of pain, and this is often a good therapist, is very important, because sometimes insoles can revolutionize someone's life. Other times, it's different orthosis, but other times it needs to be drugs for nerve pain. Other times, If somebody with CMT1A begins to get a huge amount of nerve pain, I would think that's very unusual, and I would check to make sure they haven't got diabetes as well. Is there something else causing the nerve pain? Is their B12, is their vitamins okay? So they need an MOT of the other things that cause nerve pain. So nerve pain happens, but if you suddenly get way more pain than usual, that rings a warning bell that there's something else happening. CMT doesn't protect your nerves from other diseases, okay? And I think I just mentioned here about drugs. Now, luckily, with one major exception, the vast majority of drugs that cause neuropathy do not cause it more commonly in CMT. So just because you have CMT doesn't mean you can't have a statin, doesn't mean you can't have other drugs that might cause a neuropathy. Although, to be fair, if you've got some symptoms and add a few more on, it might make things worse. So we always say, if a drug has the potential to cause a neuropathy, if you have to have it, yes, but if there's an alternative, that's better. So it's a balance of risk. There is one drug which is called vincristine, which is a very rare drug, which I hope nobody here will ever need because it's for chemotherapy, commonly used for children with leukemia, that for some reason, which we vaguely understand now, in CMT1A makes people dramatically worse in a few weeks. So we've seen people end up being in an intensive care unit, and it's due to something it does to the nerve. So that's one that is contraindicated. It means it should never be given unless it's a life-saving decision, and there's almost always other ones available. So that's what we get phone calls from Great Ormond Street, which is the paediatric hospital near me, quite a lot about that particular one. Then the other myth is CMT is not a serious condition. I'm not saying that, that's a myth. So that's a medical myth. So very much perpetuated in NHS, in GP practice. Oh, it's just CMT. Not treatable, not serious. It's not cancer, it's not serious. Now, CMT, in my opinion, is irrelevant because all that's relevant is the patient that has CMT. But my observation of patients is, yes, the vast majority of patients have a normal lifespan. So if you're going to live to 100, you live to 100. But it is a serious condition in that it is quite disabling for a lot of people chronically throughout their lives. Now, I don't know how many people here have had surgery, but I've become, over the years to realise how much of your life having an operation takes out. And people use the 18-month rule, really, to be realistically getting back to where you were beforehand in terms of having the surgery, the rehabilitation, the gradual knitting of the bones together. So some people have had 4 operations from age 15 to 20 or 25. That's a huge amount of time. That is a serious condition. So I think it is a disabling chronic condition. Now, the survey that we did with CMT UK, which hopefully will be published shortly, looked at retirement in CMT. Now, of course, people will immediately say this is biased. The fact that you're in this room means there's a bias towards people who want to know about the condition and who will engage in answering. All of those other people in the country that have CMT, we really don't know what's happening because they're not. So there's a bias here, but it still is very informative. So the median age of retirement of CMT in people, which is just less than 200 who answered the survey, was 46 years. Now clearly, there's lots of people in this room that worked much later, and it is a bias. And 81% of the people, it was retirement due to the CMT, and often that reflects where they work. Like in city practice, like London, if you need to use the tube to go to work, it's pretty difficult with CMT if you really are depending on it over a period of time. And again, it depends on what you do, whether you continue doing the job you were doing. And 12% retire before 35. So there's 12% is a big percentage of this. So it does mean people, on average, do retire earlier. I don't know how many people in this room retired early due to CMT, so I'm not going to ask that because it's an unfair question. Or when we looked at the survey in more detail, people change their job along the way. So I have a lot of patients. It's almost my heart sink when someone comes in and they tell me they're builders, or they're scaffolders, or they go up ladders, and you just look at them walking, you think, I really don't think you should be doing that. But often you're self-employed and it's very difficult actually. And we have people that fall off ladders and things. But the good thing is to get more senior so you boss everyone else around, but you don't have to do it yourself. So people do change what they do to reflect it. So one of the things that's quite important with CMT is even if you have it relatively mildly at 17, 18, is that you do make the right career choice. You know, for instance, most people will not be professional footballers or won't be concert pianists. And they realise that because hands and feet function isn't 100% normal. But we do get people picking careers which challenge them. I have a number of patients who are policemen or policewomen. And that can be fine, but actually if you're on the beat day in, day out, you might tolerate it for some years, but it's unlikely to do it for a whole 30-year police span. And for some reason, people like to be policemen that have CMT. I don't know why. The other one I find very commonly people pick to do is childcare. Now, childcare is fine, but if you're looking after really small children and your CMT is a bit more severe, it might be difficult to run after them or to do fine buttons. So it does vary what people do. So I do think it's a serious condition in the sense that it's disabling and needs just as much work put in to try to help people as not. And then finally, I'm going to dwell for a few minutes on inheritance myths. It means the genetics. So the number of people that come to clinic and say, well, it's just males, it's just females, won't affect me. So people understanding, and often that's because they've been told the wrong things. And also, I think because we're bad at counselling people. So if people that know me in the room that come to my clinic, when people come back to me for the second time, I often say, it's exam time, what did I tell you the last time? So if they haven't followed what I've said, it's my fault. Now sometimes as we do so much in the day they come, by the end of the day when I'm having a chat with them, they're looking, I need my coffee, I'm brain dead. So part of it is information overload. Part of it is they haven't gone to the CMT UK website and read up all of the information that's there. But it's trying to understand it. So what are the myths? Well, the commonest form of CMT in the UK is straightforward autosomal dominant. And if you look at the father over there, the one in white, sorry I can't point now, he has an extra, he's got 2 little bits on one chromosome, so he's got the gene. So in autosomal dominant, we all have 2 copies of every gene, one from our mum and one from our dad. All of us have 20,000 gene pairs. So there's a lot of genes to go wrong, 20,000. Now this one particular gene in the father, all you need in this case is 1 normal copy and 1 abnormal copy. It's called dominant because the abnormal copy has won the game, if you put it. So if you have 1 abnormal copy, now whether you're a man or a woman, to have a child they have to get one or the other copy of your gene. So it's a straight 50-50 that your children will have a 50-50 chance of having the disease, whether they're male or female, and it's equally severe in men or women. And this is the commonest form, and this is CMT1A. And that's a picture of what a family tree looks like. Men can give it to men can give it to women. Women can give it to men, women can give it to women. But in this, if you look back in family trees, it has to start somewhere. So many of you in the room will know your relatives have had this, but other people, it started in them. So there's about 6% of people with the common type of CMT that it starts in that particular person, but their children still have a 50-50 chance. The second, which is rarer, is what's called autosomal recessive. So this is, if you look at the young girl down here, sorry, the boy in blue at the end, this is where you need 2 copies of the abnormal gene to have the disease. So if you have 1 copy that's normal and 1 abnormal, you're a carrier and completely normal. So the parents here have 1 abnormal copy and 1 normal copy. And when they had children, there was a 1 in 4 chance the child would inherit the 2 abnormal copies. Now, the commonest condition in the country that is autosomal recessive is cystic fibrosis. Most people will have heard of that. It's relatively common. Every one of us in the room carry 5 or 6 abnormal genes. But luckily, usually we have children with someone that doesn't have the same abnormal gene, which is why we always ask about cousins. So if cousins marry, they're more likely to have genes in common. So in ethnic groups where there's first cousin marriages, this is more common. But it can happen randomly as well, just by luck. Because, we're all related if you go back far enough. At least, most of us, if you go back far enough, we're all related. Most of us. Now, the other form is X-linked, and this causes most confusion. I'm going to focus you on the bottom right diagram. To be a woman, you have 2 X chromosomes. And the lesser of the species, the man, has 1 X and 1 Y. We cannot get around that, it's the way we are. Now, X-linked CMT, the problem is carried on the X chromosome. So if you're a woman, you have 1 normal X and one X with the gene. So your children, to be your children, they have to get one or the other X. 50% of boys will get it and 50% of girls. So if you're a woman with X, it'll be 50-50. But women have a good X to make up for the bad X and men don't. So women have it much milder than men usually. But if you're a man, and if it's on the X, to be your son, they have to get your Y, and to be your daughter, your daughters have to get your X. So if you're a male with X-linked, all of your daughters get the gene and none of your sons. But generally the daughters are fairly mildly affected. So that is different. That's the one that's different. Does that make sense? Because that's commonly misunderstood. And finally, the last myth is there's no treatment for CMT. That is absolutely untrue. There is no curative treatment for CMT, and Geeta will deal with a lot more of this afternoon, but there's a huge amount of things that need to be dealt with. So to be not allowed to go and see the appropriate clinic or teams because there's no treatment is absolutely unfair. It is a manageable condition. All of you in everyday life manage it. Whatever you're doing, giving yourself longer to get to the train, to whatever you're doing, you're managing a condition. So there is lots that can be done, and there's lots that should be done, but it is treatable. And finally, there are more things happening in the future. So I just thought I'd give one research type slide. So all of these 85 genes, they're all involved with different things, but I've put in red what we're beginning to find is that even though multiple people may have very rare genes, we're beginning to define what are called pathways. And I think the future of treatment will be treating the pathways, because you're never going to be able to develop a drug treatment for one family. But pathway treatment is really where we're beginning to do a lot of research in. And finally, I'm glad someone mentioned the foot photograph, because I love this photograph. This is one of the most powerful slides we show when we give talks around the world, because it's from CMT UK. So you have one with feet already. Is this just an old one?
Yeah, we're just going to redo it.
Well, I think it's a great one. And the reason is, if we're talking to people that don't know about CMT, so this tells them immediately it's length dependent. So medically, it clicks immediately, it's your feet. Number two, it shows you that people are very different. No two feet or no two pairs of feet are the same. And number three, it shows you what patients that come into clinic, we might have all these sophisticated explanations, but patients come complaining of the feet. Their hands as well, but generally, initially, they complain of their feet. So I think that picture speaks more than almost all the talks. And I really think the idea of the hands and feet is such a good way of getting the message across. Finally, I'm just going to acknowledge the research team in the middle in the lab, the clinical team on the left, and the diagnostic gene team. But I thought for this talk, I would say two final slides. One, I'm going to acknowledge the people that really make life work for me in terms of looking after patients. Geeta, who's going to talk this afternoon, is just a fantastic physiotherapist who's done a PhD and is really an academic physiotherapist who's really driving research into the physiotherapy of CMT. Karen Bull, who's our neuromuscular nurse specialist, who unfortunately is going to retire this year, but we've persuaded her to stay 2 days a week, is an excellent nerve specialist. And if you do in your area have a nerve specialist, they can really help just deal with the kind of things out there, inform the GPs, get the right care, etc. The other thing is we have a duty for the future to grow up specialists. So one of the things we've been very interested in is educating people. And since I ran CMT in Queen Square, since I took over from PK Thomas, we've grown up 3 new consultants. One who I'm just going to introduce, Matilda Laura, some of you know already, she's been a consultant for about 3 years. She exclusively sees patients with inherited neuropathies, and her main area of expertise is the management of the orthopedic complications, the pain, and the medical complications of the disease. Jasper Morrow in the middle is a young consultant. He's just been appointed about 2 months ago, and he's a lead in developing the MRI scanning, which CMT UK have partially funded, so developing ways of measuring CMT. He's a very good clinician. And Alex Rosser is the newest kid on the block. Alex is just about to become a consultant with us in August. He's trained under us, and he's very much involved in the lab and developing therapies. And finally, what about the rest of the UK? Now, I've shown this slide and it's grown. There's a little extra bit in it since the last time. This is not to say CMT isn't looked after all over the country. There's some very good consultants looking after patients. But what I do is I have a map where there are clinics that both do clinical practice and research, just to show you where it's happening. And someone here pointed out the last time I showed the slide that I got Oxford and Cambridge wrong. I've corrected it, I've learned. So in London, I lead a clinic. David Bennett has moved to Oxford about 5 years ago, and those of you that are in the Oxford area, he's an extremely good consultant. His area of particular expertise is pain neuropathy. So he does a lot of genetic painful neuropathies that are not CMT, but he's a particular specialty in pain. Rhys Roberts in Cambridge is, I should have said Rhys Roberts in Cambridge is, he runs a clinic for CMT in Cambridge, is an extremely good consultant. Rita Hovard covers Newcastle. The other person that was Newcastle, Patrick Chenery, has moved to Cambridge. And the latest person on the block is Katie Brennan in Glasgow. Now, Katie comes from the same part of Ireland I come from. I didn't know there was another neurologist in that part of the country till Mike Shy told me in the States. So she is from Mayo, way over on the west coast of Ireland, went to Glasgow to medical school, and then ended up in Iowa, where Mike Shy is, because her husband was doing a sabbatical there. And she is trained in CMT and has come back as a consultant to Glasgow, appointed about 2 months ago. So she's a young, enthusiastic, extremely knowledgeable person in CMT as well. So every time we get new people, we'll add them into the map. That map isn't for clinical care alone. There's lots of very good people, but it's just in terms of people who are new with new research interests. I thought it might be useful for people to know. Now, I have been given some questions already, and I'm happy to address those first, and then take any further ones. But before doing that, were there any questions from my talk that anybody wanted to ask? Or will I just go straight to the questions?
What was that medicine that you mentioned?
The one not to take? Yeah. Vincristine. Some people have had it in the past, but it wouldn't be given now. It's only not to be given in CMT1A. The other forms of CMT, it isn't as much of a problem, although we'd all be a bit nervous about it because it's not as clear, but it's CMT1A specifically. But clearly, you know, I'm not saying it can never be given. If somebody has cancer and somebody has CMT, and if there was no other treatment, you would take it. But generally, in 2016, there are other treatments they can give, generally. But it is one of the reasons sometimes we get a phone call about a child who doesn't have CMT, but one of their parents do. And the parents know the diagnosis, but the child has no symptoms. So in that case, we would recommend genetic testing is done urgently before the chemotherapy is given, because it can bring out the symptoms. So that is one of the exceptions to us doing something really urgently. Any other questions from the talk? Okay, sorry.
Nerve pain.
Yeah, so nerve pain, as I said, about 18% with common CMT have it, but there is a form of CMT where it's very common. So in terms of treating nerve pain, generally paracetamol and non-steroidals like Brufen don't work brilliantly for nerve pain. Sometimes they work a bit. And usually you have to go to nerve-specific medications. And generally you cannot take them like you would take a Panadol if you have a headache. You have to take them to prevent the pain. So drugs that were developed for epilepsy originally, like gabapentin and pregabalin, are commonly used for nerve pain. And then there's another group of drugs that were originally developed for depression, like amitriptyline, duloxetine, that are also used for nerve pain. The other thing, which was another myth, which I didn't put up, the myth that's gone, is when I was in medical school, we were told that for any neuropathy pain, not just CMT, so if you had nerve pain, morphine didn't work. It's something we were all told, and people all thought morphine didn't work. I'm not recommending morphine, by the way, but morphine, in the commonest form of GPs used, is called tramadol, is now known to work well for nerve pain. But it's never given in CMT, almost, because most people don't need it, because morphine works for lots of pains. But they're the ones that are generally used for nerve pain. There are things you can use that are put on the skin as well, local anesthetic type creams, etc. But gabapentin is probably the commonest one used because it's well known and is fairly well tolerated in most people. Often, though, people are not given high enough doses. So often people are started on small doses and it's meant to go up, and then you see them a year later and nobody's moved it up. And that may be a reason people think they don't respond. So with pain, if you've been given a trial of a treatment, to say it doesn't work, we need to make sure you've been given an adequate trial, Because if it doesn't work, did it not work because you were given enough and it didn't work, or you got side effects and couldn't tolerate it? So we always want to know which of those two things. Okay?
Just a question. I was interested in your slide about people retiring due to CMT, and I suppose what I was thinking, which I'm really interested in, is why did they retire? What is it about the CMT that stops them doing the job? Is it the wrong job? And I suppose I'm just asking, do you have any more thoughts on it?
Sure. So I do. I think that's a very good question. So I said one of the major issues is getting to work for some people, depending on where they live. I would find the biggest reason people retire, that may be the wrong job. So they may be in a job they cannot do. So if you're a builder that goes up on scaffolding and you're self-employed, there comes a time when you can't go up the scaffolding, to be fair. And I think that's one of the reasons. And there's not always an alternative job if you're manually based. That's another reason, although there often is. But the commonest reason people give to us is fatigue. So fatigue is a very big part for CMT for some people, but not for others. Almost everyone with CMT, I mean there are exceptions, but almost everyone gets fatigue. And Geeta has a particular interest in managing fatigue. Now why do people get fatigued? Well, there's the simple physical fatigue, is that everything is hard to work. So if I jump down here and run over to the chair, that costs me no energy. But if you have CMT and have to physically lift your leg up, lift it down, it takes some energy. So there's the physical fatigue. And over a day that becomes worse. You may have energy in the morning, but as the day goes on, it gets worse. But there's a fatigue that's more than that to do with having CMT. So we know that patients with CMT develop fatigue, some people, that's more than just the physical, and we don't quite understand that, but we recognize it as part of it. And there is a third part of fatigue, which I mentioned, is if you have sleep apnea, fatigue can be a major problem. So one of the things we always try to do is make sure there's nothing like that. So I do think, I would say one of the commonest things with CMT people retiring early is fatigue plus a combination of other things. It depends on your workplace, how good people are at adapting in the workplace. Everyone isn't equal. Sometimes you find people who are teachers, for instance, that eventually people don't make the adjustments that they should do to them moving around. So it's a combination of factors, actually, I find.
Thank you for that. Just last question, that there's a lot of quantitative research out there, there's not qualitative. Is there anything around sort of what I've just asked, and why isn't there the qualitative research, getting the real people's experience?
So I think why isn't it? Well, because I think it's something that's very difficult to fund. I mean, we're interested in this, and Geeta has been leading this, and one of the reasons for doing the survey was to get some real-time data on it. And I think it's actually, it's quite difficult to fund research unless you can prove that you're able to measure it very well. But I think it's a very important thing. I think absolutely it's important. And one of the reasons for doing this survey was, in England, what's been weird about the health service is there's the health service and there's the social service. It used to be funded very separately. And if people got their heads around the fact that if everyone is retiring early, they're actually, society, money-wise, it's costing more to society, and it's costing to the patient's quality of life, and all of that adds up to a cost in some way or the other. They might put more funding into it, but that kind of big picture look is actually quite difficult to get across. I entirely agree there should be more research in this, absolutely. But I think working out how to do the research well is what's more difficult. Okay.
Hello.
Hi.
Just got one question about maybe you call it secondary symptoms, like the sleep apnea and whatnot. Is that, say, for example, choosing sleep apnea as an example, is that something that you'd treat as CMT specific, or is it like treated as, that's a separate issue, so we're going to deal with that like we would any other sleep apnea?
So you're right, the treatment of sleep apnea is the treatment of sleep apnea. It's a bit like, if you fall and fracture your leg, you're not going to get a special CMT surgeon, a special CMT operation if you need an operation. You get the right operation for your leg. So the treatment of sleep apnea so if you went to see someone with sleep apnea, they would look to see if there's anything they can do easily, like can you lose 2 or 3 stone, which is usually what people say, which is clearly more challenging when you have CMT than otherwise. Or is there something simple? They often look to make sure you haven't got something wrong, obstruction. So some people have something wrong with their sinuses, their nasal, their tonsils that can be rectified by an operation. But most people get given what are called masks to help them. They get CPAP machines, they get machines overnight to help them breathe. And that would be the same kind of machines, whether you've CMT or not. So if I see someone in my clinic with it, I refer them in our hospital to the people that look after sleep apnea. The fact that they've CMT doesn't mean they get different treatment. It's the same treatment, but there's an extra cause. If you ask my honest opinion, most people with CMT that get sleep apnea, it is contributed by other causes, but it is more common generally, so there has to be some contribution from having CMT. But you're right, people with CMT go to clinics and people will say, not my area, this is not my area, and it's a matter, and I find with people when they go to their GPs, and this is, I'm sympathetic for GPs with this, they don't know much about CMT, and you'll come with some new symptom, and they'll say, so I have no idea. Now the commonest phone calls we get are people who clearly have another problem. The number of people with severe hip problems that ended up having hip replacements, that people said we don't know what this is because you have CMT. So it's a matter of people knowing the disease, not for the disease itself, but to make sure they recognise when there's other common problems that happen. It's just because you CMT, with age, people get all the normal age issues as well. Okay, maybe I'll deal so we don't discriminate against the people, because there's just 5 questions. Actually, I have to say, these are almost the best questions I've ever had done in advance. Now, what somebody wrote is severity of symptoms with CMT vary massively, even within family members. Is this usual for neurological conditions or just for CMT, and do I have any theories? Well, that's a very good question, because a lot of people around the room may be in a family that you have exactly the same genetic defect, and yet the variation of severity within the family is big. It's actually not as big for CMT1A as some of the other forms of CMT. We see even bigger discrepancy with some of the other forms of CMT. This is extremely common in genetic diseases, not just neuropathy. So any kind of genetic diseases, we know that one of the things we don't understand very well is the variation in severity. So the simple explanation for this, which is not the common explanation for CMT, is there's something environmental. For instance, if you have CMT, and let's say by 20, you're 20 stone, and you develop diabetes, and you develop something else, and then you decide to become an alcoholic along the way. Now, clearly, you're going to be much more severe than somebody else. Now, that's an extreme example. So sometimes there's an environmental thing that is making things worse. But in the vast majority of people, it's not that. It's usually something else we think genetic. So what we know is that those 20,000 genes I talked to you about, the interesting thing we've only kind of worked out in the last 10 years about is that only accounts for 2% of all our genetic material. So there's 98% of our genetic material that we know nothing about. So we think there are these things called epigenetic factors. There'll be other bits of our DNA that interacts with the CMT gene to work out how you as an individual look. Because even when you're very closely related, like your father, your mother, your brother, your sister, unless you're an identical twin, you don't have exactly the same genes. They will be different. And we have evidence for that already with some forms of CMT. So with some forms of CMT, we know that if you have a variation in another gene, that will make it more severe or less severe. And of course, that becomes interesting because that might be a drug target. So that, I think, is the commonest reason. And I think that's the commonest reason for variation that we see in families. I do think, though, you'll know yourself, I think some people are good at looking after the disease and some people are better, so we'll have patients who have very severe sensory problems, say, and the good person that goes to the chiropodist, the podiatrist that does their nails properly, that looks after the skin, will come back to clinic very well. The person that really, particularly if they're a teenager and they're just going through a phase of, uninterested in the world and the universe with their condition, don't look after themselves, may have had a very difficult year, and then they may develop complications. There is a little bit of that. We've emerging evidence that being fit is helpful for CMT. It's harder, but the patients that find some way of keeping fit, be it an exercise bike or whatever way you find for yourself, they definitely do better in the long term in terms of developing symptoms. But there's no question, the biggest variation is due to other genetic factors. There's no question in my mind it is, and we don't understand it. And one of the most difficult things for us with patients is when we're telling you about the genetics that your child will have a 50-50 chance. The next question we're always asked is, will they be like me or like my father or mother? In other words, can you tell me how severe they will be? And we cannot. So we can tell you they'll have a 50-50 chance of having the disease, but we actually have zero way yet of knowing where they will come in the severity, except to say in your individual family, whatever range is in your family is probably the range they'll be within. So certain families have a range that's different from another family of severities. So the second question was, and they said this, Karen helpfully said I shouldn't answer this, that Geeta would be better at answering it. It was, what are the most important things that people can do to help themselves stay mobile for as long as possible? And I'm sure Geeta can help that, but basically it's staying fit. And everyone's way of staying fit will vary with their disease. And it's you know, access to hydrotherapy, access to pools, access to gyms, all of this varies across the country, varies with individual people. And of course, the thing that works best is the thing you can do at home easiest. And whatever that is for individual people is important. So keeping fit in whatever way possible is very important. And I think also, and this is something which I know comes up, is, you know, this might sound a really obvious thing to say, but we don't like people having fractures. Now, as I said, this sounds very obvious. We really, really don't like people falling and fracturing. Now, it's just not that we don't like people having pain and the discomfort of a fracture, but you know if you've had a bad fracture, you just don't quite ever get back where you were. It leaves damage. You're off your legs for a while, you're in a plaster cast, so avoiding falls. Now, that may mean, I know people laugh, because some people can't avoid falls. So how could you actually avoid a fall forever? Well, you'd never stand up, and that's not real life. But there's some people that discussion becomes an important one. For very rare forms of CMT, they're more severe. Are you safer in a wheelchair out of the house? And there'll be people, I'm not saying if it's males or females, that are resistant to this, that think the minute they use a wheelchair, it's given in. Except in an airport. Everyone accepts them in an airport. For some reason, I never have trouble talking people into using a wheelchair in airports. So I think the other question is orthotics. Now, that's a difficult one, because all we do is advise patients. So we might give you the perfect set of orthoses and look at you walk, and you look like you walk better. You leave us and you throw them away. Because even though you have very severe foot drop, that is the way you know yourself, and that's fine. And that might work for some people, but if you're tired in the evening, you lose concentration. That's when you need to be very careful. So all I'd say is, for each individual, is developing the way that works best for them. And I'm being very careful how I put this, to try to avoid falls. And you can't avoid them all the time. But falls are difficult, because if you do fracture something, that's a problem. So I would say, you know, as a woman, as you get older, make sure you don't have, your bone health is good, that you don't have osteoporosis. Make sure your bones are healthy. That there's no if you fall, you don't want to have more risk of fracture than anybody else. Things like that. Geeta will address that more. Now, a very good question, the next one. Are people with CMT more prone to carpal tunnel syndrome, and is the treatment the same for people with CMT? Now, carpal tunnel syndrome is you have 8 bones in your wrist, and you have one nerve, which is called the median nerve, that supplies these 3 fingers. So it gives you sensation for these 3 fingers. And when you have carpal tunnel syndrome, that becomes tingly and numb, and you tend to do this. Often worse during the night, so you wake up, shake a bit, go back to sleep, wake up, shake a bit. And if it's very severe, you can either wear splints to help it or have a little operation to release the pressure. The problem is it's incredibly common in normal life. So the causes of carpal tunnel syndrome, the common causes, are not CMT. It's fractures. You can get it if you had a fracture to the wrist, rheumatoid arthritis, a problem with your growth hormone, which people don't have, pregnancy, which half the population can't have, steroids, and putting on a lot of weight. So if anyone's had carpal tunnel syndrome, you'll know that if you put on weight, it gets worse, and if you lose weight, it goes away. But in my opinion, it is more common in CMT. I do see people complain of it more common in CMT, and it's very difficult to diagnose, because all the tests we do all the criteria that are defined are for people with normal nerves. Do they do as well? No. So if you have an operation for carpal tunnel syndrome, by and large, the outcome isn't as good for CMT. So what I do in practice, and I've learned this over years rather than it being taught, is if your symptoms are bad enough to warrant surgery, and the only symptom that I think does well with surgery is a lot of tingling and pain. So if the symptoms are very bad and need surgery, we do recommend it. But we always say that the chance of doing as well as someone without CMT is less. So it's a balanced discussion to have for the individual. So yes, you sometimes need surgery. probably not as common as people without CMT, and you don't usually do quite as well, but some people can do very well. So it is more common in my opinion, and in certain forms of CMT, I have a feeling it's more common again. Next question, they're getting easier, like not. Why exactly do the physical symptoms occur, the curled toes, the high arches, etc.? So what we think happens is the reason you get the bony deformities like the high arch and like the curled toes is due to the weakness of individual muscles. And the muscles are individually weak because the nerves don't work to the muscles. And your bones develop very much as when you're growing up. You know, you stop growing at about, I suppose, some of us a bit earlier than others, but maybe, 19, 20. But if you have CMT, and most people do start during those years, it does mean, particularly when you have the growth spurt, that actually it's a difficult time. Because if you look at some men particularly, they can grow a foot in a year, some of them. Incredible. And think of what your body has to do. It has to grow your bones, your muscles, and your nerves that quickly. And if you've CMT, that's a challenge. So I think that most of the physical symptoms due to weakness are due to the nerves, the muscles not working, and then the secondary complications of the bone, etc. And even though the problem can be in the myelin or the axon, it tends to be, it's the axon that causes the problem. You can kind of get away without myelin for a while, and that's why children with CMT1A often are normal initially, or fairly normal, but when the axon begins to die off, it's when they get their symptoms in the teenage years. So that's what most of the physical symptoms, and the other ones, the pain, the tingling, the numbness, are due to your nerves not working properly. So it's all back to the nerves, but it can be the nerves, the damage they cause to muscles, and the damage they cause to the joints. If you walk around, and with the common form of CMT, it's foot drop, it's your ankle coming up, and the ankle going out the whole week, so you tend to twist all the time, twist and turn in your ankle. And that is due to the nerve problem, because the muscles are weak, but eventually it causes difficulty with the ankle. And for some of you will have had it, but ankle arthritis is not uncommon eventually. If when you've had CMT for a long time, if you constantly traumatize a joint, and CMT, if you twist your ankle all the time, you're more likely to get arthritis in that joint. So I think there's a higher instance of complications like arthritis due to the problems with CMT. And finally, and this is a good question as well, which we've slightly dealt with earlier, can the sensory nerve damage manifest as other weird sensations, other than just pain, burning, stabbing, the usual reported ones, like intense itching on the skin? So the sensory nerves are incredible. So we talk about negative and positive symptoms. So negative symptoms of sensory nerves are lack of things. So lack of feeling, numbness, they're all lack of normal feeling. And that is the commonest in CMT. So most patients, when they come to us with CMT, we have to drag the numbness out of them. They will say, I'm weak, I can't walk, and I'll say, well, have you lack of feeling? And they'll say, well, when the doctors examined me, I noticed it. But I didn't really notice it beforehand, but I'm worse than the cold. I'm definitely worse than the cold. So there's kind of a repeated story we get, but most people, it's the negative symptoms, or they've developed a little ulcer, the complication, because they couldn't feel. Positive symptoms, there's a vast range of them. Tingling, pins and needles, the word paresthesia, if you've had a local anaesthetic for your teeth, when that begins to wear off, that funny, weird tingle that comes back, stabbing pains, shooting pains, itching, are all positive symptoms. They are rarer with CMT, but you do see some of them, particularly the pins and needles and the pain. Itching is a very rare symptom in CMT, but is common in other forms of neuropathy. But in CMT, it's not one I see often, this constant itching feeling. There's another symptom called formication, just so I get that right. It's a feeling of ants crawling underneath your skin. Again, it's a weird feeling, but uncommon in CMT. So CMT, commonest the negative feelings. You can get the positive ones, but the very weird ones people get are less common, but they can be seen in some of the rarer neuropathies. Okay, that's all the questions. I'm happy to take any more. That's all the ones that were sent. Go ahead.
One of the things that came out of one of the research
You're working, Jason, very hard.
One of the things that came out of one of the research projects was that there's a relationship between HTTP and CMT1A, that some people lose
Yeah.
their gene for that causes the HTP, and
Yeah.
also get a
Yeah.
duplication of the
Yeah.
CMT gene. How common is that?
Sure. So basically, CMT1A, the gene peripheral myelin protein 22, PMP22, makes a protein that is in our myelin. If you have CMT1A, you have an extra copy of that gene, so it's called a duplication. So one of your chromosomes has one copy, the other chromosome has two copies. So you have three copies. So normal people have two, CMT1A have three. And then there's a condition called HNPP, hereditary neuropathy with liability to pressure palsy, where you've lost a copy. So you have one chromosome with one copy and one absent one. So what you can have is one copy, two copies, or three copies. And there's the occasional patient around the world with four copies. So if two people with CMT1A have children together, there's a 1 in 4 chance their child will have 4 copies. Okay, my very first CMTA conference ever for CMT UK was 2 people asked me what were the chances of that we're about to have children. I do remember that question. That was challenging in a CMT meeting. So what that tells us, and we've now proven that through research, is that the dose of this PMP22 protein is critical. The reason, it's something very exquisite about the dose. So too much or too little causing neuropathy, but you just need the right dose. Now, we kind of know why that is, although not sure it's because of its interaction with other proteins. The problem, as you can imagine, treatment-wise, is what we've been trying to do is develop treatments for CMT1A to reduce the dose of PMP22. But if we get it wrong and go too little, you might get hereditary neuropathy with liability to pressure palsy. And the people that have 4 copies are generally a little bit worse. Now, there is a human experiment, if you want to put it this way, just been published. I knew of one other case, but they weren't published. And if you just concentrate for 1 minute, this proves that the dosage is important. There is a family where the mother has the usual 3 copies. They have CMT1A, and the father has HMPP. He has 1 copy. One of their children inherited, and I wish I could draw this, the chromosome from the mother with the 2 copies of the PMP22, and the chromosome with the father with no copy. So even though they have a very abnormal genetic makeup, they have 0 copies on one chromosome and 2 on the other, the patient is completely normal. They're absolutely 100% normal. So it didn't matter that they got the 2 copies from one parent. As long as you have 2 copies, you're normal. So that's the absolute proof that it is the dosage. Now that's the perfect human experiment. I'm not suggesting we do human experiments. This is clearly, but in terms of, it told us more than maybe 20 years of research, that actual occurrence. It proves that it is the absolute, so it's a bit like looking at a structure where just a tiny bit off of one bit of the structure is really important. That's where we are at it, but it does make the treatment really important to get the dosage right. Okay, I'm not allowed to answer any other questions, but I'm always happy to take them unofficially. Thank you.